Okay, my topic of my presentation is very simple in reality, because I want just to underline, according to our experience, the importance of prophylactic peripheral endolaser in macular surgery. Because we know that retinal detachment, post-vitrectomy retinal detachment is very dramatic, or even if very, very low, with a low incidence, but very dramatic complications. So we started with in our approach to macular surgery with this treatment, peripheral treatment at the end of the vitrectomy. I present our experience of these 162 consecutive patients operated with the three systems, 23, 25, and 27, with a standard technique that consists in particular in a peripheral complete vitrectomy and peripheral endolaser, sometimes with 360 and sometimes only just under the sclerotomies. Just to underline that from the point of view of technical, Okay. And just to show in this slide, sorry, the video doesn't start, that in particular infected patient is not so difficult to do, yes, in particular the right video, thank you. It's not so difficult because with the use of a chandelier in the trocar, so avoiding further sclerotomy, I usually make a scleral depression on the side of the vitroscatter, so avoiding to cross the lens. And how you can see on the right, on the left side, you can do an easy, very peripheral shaving without having risk to touch the lens. And I think that this maneuver at the end of vitrectomy is very, very important. Then the same we can do with the laser, on the same maneuver, first on the left, then on the right side. And it's very easy, and I think very effective, because our very little, I can confirm, very little experience, however, shows an improvement of the visual acuity with an important rate in terms of results, in particular for the absolute absence of post-operative retinal detachment. Just one intraoperative. Maybe the occurrence of macular edema can be a kind of little complications, maybe for the application of laser, we don't know. However, I want just so to underline that in our little experience, and I can confirm without a control group, this technique is safe and maybe also effective in terms of quality and visual acuity and safety for the patient. Thank you.
And now from the discussion.
I make a very short. I totally disagree with this paper. Number one, for macular surgery, you don't have to do a peripheral vitrectomy and vitreous shaving. That's number one. And number two, I have never seen retinal detachment after macular surgery. If you don't go very peripheral and vitreous shaving, you won't see any iatrogenic breaks. So personally, I do not do any prophylactic laser for any kind of macular surgery. And they asked this question in the American Academy of Preference and Practices. The Americans don't do prophylactic endolaser, so I disagree with this paper.
I also agree that your comments, and you presented some patient had developed CME because it's from that by the lasers.
Have you heard the question? Do you think that the macular edema was induced by the laser? You can't answer that.
Sorry.
Because you always observe macular edema with or without, yes, even by the peeling, yes, so we cannot really comment. You basically raised one of the typical topic, peripheral vitrectomy versus core vitrectomy. You reported a few retinal breaks. How many of those retinal breaks were induced by you doing peripheral vitrectomy?
In this report, there was one retinal detachment. I don't remember, but probably a couple number of retinal breaks. I can confirm that the shaving can
But
be
you made the break, or they were present already?
Some were present, some we made, in particular in the induction of posterior video detachment.
Dr. Mortada?
Yes. Ivanovic stated that vitrectomy is done when the vitreous is gone. So I totally agree that we have to shave the vitreous base in these cases, not only because of removal of the peripheral gel, but to look for peripheral breaks induced by posterior vitreous detachment. And I have seen many retinal detachment referred to me and done by myself during peeling of the posterior halo. Do not know where are the areas of a strong vitreoretinal attachment. And if you do not indent the globe for removal of the vitreous, or at least to see what breaks have been induced.
I agree. We went through this discussion many, many times. How many of you for the core vitrectomy? Raise your hand. And how many for complete vitrectomy, even for a bugger? So it's half and half, as usual. I thought so many times about that, and I thought, where's the truth? I changed the technique myself so many times. In the end, tell me what you think. I think that you have to check the periphery. No matter what you do, you check the periphery. If you see a break, you treat it. If you don't see a break, you don't do it. You do nothing. There's always a chance that if you do more, you induce more problems. That's it. So I think that in the end, you have to leave the periphery of the eye in order. And that's the key point, right? And some of us feel better by doing the whole laser, and some of us just leaving the eye as it is. But, okay.